Brilliant. So welcome everyone to Epilepsy Research UK's webinar on SUDEP Awareness Day. We're joined this morning by two of our funded researchers, Dr. Susan Duncan, a consultant neurologist based at the Edinburgh and Lothian Epilepsy Service, who in 2015 was awarded an Epilepsy Research UK Endeavour Project grant to review the causes of epilepsy-related deaths in Scotland over a 5-year period. We're also joined by Dr. Amal Bandare, who is a neuroscientist based at the University of Warwick. And in 2019, Dr. Bandare was awarded funding by Epilepsy Research UK to investigate the underlying mechanisms of sudden unexpected deaths in epilepsy, known as SUDEP. We're also delighted to be joined by Andrew Peaple. Andrew is a former journalist who now works as a director of research with a UK-China trade group and also co-hosts the Asia Matters podcast. Andrew's family experienced the tragedy of losing his sister Claire to sudden death from epilepsy in 2002 when she was just 25. Andrew, who was working in Tokyo at the time, has since lived and worked in Beijing and Hong Kong, as well as London, but is joining us today from the village in Kent, where he now lives with his wife and 4-year-old son. We've also had some excellent questions for our researchers that have been submitted to the Epilepsy Research UK team. So welcome to all of our speakers. And with journalistic and presenting credentials like Andrew's, all that's left for me to do is to hand over the reins. So thank you, and over to you, Andrew.
Well, thank you so much, and thank you for having me today. It's a great privilege for me to be able to take part in this webinar and to speak to Drs. Duncan and Bandare, who are doing such valuable research. As Quiva said, my family, we suffered the loss of my sister Claire. It was back in 2002, and we obviously knew that Claire was living with epilepsy, but I don't think any of us really realized that it could be something that she would eventually lose her life from. It was obviously a very traumatic time, very devastating time for our family. Claire was at home with my parents. It was actually the day before my younger sister, Victoria, who's a few years younger than me. It was just before her 21st birthday, and so everyone was gathered there. Unfortunately, I was still in Japan at the time, where I was living and working at the time, and so I wasn't there. But Claire woke up on the Saturday morning, and well, that was it really. It's difficult to go through the exact details, but it was it was very sudden and unexpected, and I obviously flew home straight away from Japan. It was a horrendous journey, as you can imagine, and we went through that period of intense grief, and it's still a loss that we think about every day, even today, of course. Claire was, she was 3 years younger than me. She was a lovely person, very kind, interested in music, very artistic, just a fun person, always laughing, always laughs around being around Claire. I just remember, because it was the early days of email back then, and even in her little emails, even about just mundane things, there'd just be a funny line in there or something quirky that would make you laugh. And so, we just miss her so much still. And, I think at the age of 25 as well, what was so cruel in a way was that, I think most of us in our 20s, we go through that period where you're becoming an adult and you're leaving your student days and your school days behind you. And Claire was really there. She was a young woman, just with her whole life ahead of her, and it was a terrible loss. And of course, afterwards, you realize epilepsy, it's such a difficult subject, the brain, how the brain works, such a complex subject. I'm no scientist myself, and you realize, in a way, how little was known about it back then. And so it's fantastic for me and my family to see organizations like Epilepsy Research UK supporting the research that is still so badly needed, and in particular in this area of sudden death from epilepsy. So thank you for letting me explain my background here and our experiences with this. I'm going to hand over now, though, to Dr. Susan Duncan, and she's going to be explaining what SUDEP is, sudden death from epilepsy, and talking about her research team's recent research into epilepsy-related deaths, particularly the research that was funded by Epilepsy Research UK. So thank you for that, and over to you, Dr. Duncan.
Well, good afternoon, everyone. Thank you for the invitation. And first of all, I'd like to thank Epilepsy Research UK for supporting our research, and I'll talk a little about it in a minute. We should perhaps remember that about 1,000 people a year die from their epilepsy in the United Kingdom, and that's about 21 a week, and about half of that is due to SUDEP. And SUDEP is defined as sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning deaths in patients with epilepsy, with or without evidence of seizure, excluding documented status epilepticus, in which post-mortem does not reveal a structural or toxicological cause. So basically, the person dies because of their seizure. I was funded, along with my collaborators, by Epilepsy Research UK, to look at epilepsy-related deaths in Scotland, not just SUDEPs, but deaths in general. And it's a Scottish Epilepsy Death Study, and my colleagues pulled my leg that my name is Susan Elizabeth Duncan, so it also fitted in with my name. We decided that we'd have the unicorn as our sort of logo, although we didn't use it very much. The unicorn is the national animal of Scotland, and in mythology, the unicorn is meant to get off after the lion, and in 13th century Scotland, it was felt that the unicorn might see off the English lion. Now, Scotland is devolved for health matters. We run our own healthcare system along with our own education and legal system. Both of which feed into the study. When you enter the healthcare system in Scotland, from whatever age, and usually from a very young age, you're assigned a CHI number, a Community Health Index number, and this is your date of birth plus another 4 digits. And this is quite unique to you, and it follows you wherever you go in the healthcare system and increasingly in the social care system. So it means if you attend your GP, your CHI number is recorded and the reason why you went to your GP. And if your GP talks to the consultant or secondary care, then of course any communication is done with the CHI number on it. If you're taking anti-epileptic drugs or any sort of drug which are dispensed through the national dispense system, which they all are under the National Health System, again, your CHI number will be on your prescription, and we can trace you that way through the prescription data. Also, if you go into hospital, if you're admitted to hospital, your CHI number is recorded and the reason why you were in hospital, the diagnosis, and sadly, if you died in hospital, the reasons for your death. And that is tied up with CHI. And that then all feeds in, if you do die, onto the death record. And in Scotland, when you register someone's death, the CHI number is on the death certificate. And when I recently registered my father's death, I was given a copy of a cut down copy of the death certificate. And it had his CHI number on it. So what we did was we looked at deaths in adults with epilepsy aged 16 years or over from 2009 to 2016. So that was 7 years. We were funded for 5, but we managed to squeeze 7 years out of it because we thought that would make the data more robust. And the other interesting thing about having a CHI number is you can access all of this data from these databases and cross-reference to make sure that people actually have epilepsy and to find out what drugs they're on. But also, of course, it leads you directly to the electronic patient record. So that not only do you get big data, a panoramic sweep of 1,000 patients, what drugs they're taking, what their diagnoses were, what sort of epilepsy they had, and so on, but you can also go and look at the individual electronic patient records. And indeed, in one health board, they still have the paper records, and you could go and look at those. So we were very able to look at, as I said, this panoramic sweep of huge amounts of data, but at the same time look at individual cases as well. And at the end, I will briefly talk about one or two of the individual cases. Now, in Scotland, we have a slightly different system of death certification than the rest of the country. We changed it in 2011 because there was a feeling that it was not as accurate as it should have been. And essentially, this is the top half of a death certificate. So the condition that killed you has to go down first. So if you died of a seizure, then it may put seizure or epilepsy. But if, for example, you died of an aspiration pneumonia, it will say aspiration pneumonia. But if you had had a seizure and aspirated, inhaled your vomit during the seizure, and then died of a pneumonia, the second, at point B, it will put epilepsy. Now, these are then, of course, coded by coders, and there's an international system of coding. And interestingly, there are lots of codes. That's ICD-10G40 are the codes all around epilepsy. There is no code for SUDEP, interestingly, which means that when you look at death certificates, you have to look for all the codes for epilepsy, and then you have to trace back and look at the other databases I showed you in the previous slide, and the electronic patient records, which enable you to make the identification of SUDEP. And it's quite odd that there is no actual code for SUDEP, and we hadn't really appreciated that when we started. Although I have to say the coding on death certification in Scotland is very good. We also in Scotland have a system of medical examiners, so that if the coders are not happy with what they see on the death certificate, or if it's not fully filled out, or if it says a post-mortem is planned or further information might be available, then these are all handy to medical examiners who go out and talk to the clinicians involved. And this isn't a paper exercise. A friend of mine in general practice spent a whole day going over case notes with a medical examiner until the medical examiner was happy that he had a correct death certificate. And it wasn't just the GP he talked to, he'd also talked to a hospital consultant. So our death certification is pretty accurate. So what did we find? Well, this is a very busy slide, but the things to look at are the numbers in red. If you look at the age groups on the right side, the red age groups go up to the age of about 50. And if you look straight across, you will find another red column, and it's really the ratio of observed deaths to expected deaths. If you look at the column that says expected yearly number of deaths in the epilepsy population, it will say that age 16 to 24, 2 people per year were expected to die of their epilepsy. In reality, about 6 people did, and so on. And as you can see, if you look at actually a ratio, 6 more people died of their epilepsy than were expected to die. Aged 25 to 34, 4 times more people died of epilepsy than were expected to die. And age 35, it gets slightly lower, twice as many. So in general, people with epilepsy, particularly in their early years, may be 3 to 4 times more likely to die before their time of epilepsy. Now, in the 16 to 24-year age group, that may be because, paradoxically, of improved medical and nursing care, in that many children, infants and children who would have died of cerebral palsy, for example, or some of the metabolic diseases and genetic conditions associated with epilepsy, these people would have died much younger, 30 or 40 years ago. They're now surviving into their teenage years or their early adult years, and then they're dying, and that's one of the reasons. But nonetheless, for your first 50 years of life, if you have epilepsy, you have a significantly increased risk of dying before your time. So what did we find in our 7-year window? Well, there were 2,149 epilepsy deaths. It's about 300 a year. And I looked at notes of about 1,000 of these people. And if we look at the SUDEP cases, there were 221 SUDEP cases, definite SUDEP cases. So about 30 a year. Now, Scotland has about 1/10 of the population of the United Kingdom, so that's about 300 or so a year, UK-wide, sort of. The average age was 41 years, but the age range went from 16 to 80. I was a little surprised that elderly people being classified as having SUDEP, but certainly the preponderance was the younger age group. The majority of people were taking anti-epileptics. 61% of the SUDEP cases had no previous admission to hospital for seizure or epilepsy. Now, that doesn't mean to say they were not diagnosed with having epilepsy and they were not being seen somewhere for their epilepsy, but they had not come in, they'd not been admitted for care for their epilepsy, which is interesting. 64% were male. Well, that didn't surprise us because all of the studies on epilepsy, on SUDEP, suggest that men are more prone, are more likely to die of SUDEP than women. 60% came from the two most deprived SIMD quintiles. That's the Scottish Index of Multiple Deprivation. So poverty seems to be a marker or an increased risk factor for SUDEP. And 88% had a post-mortem. Now, in Scotland, we have a magnificently named public official called Procurator Fiscal, who is a legal officer, and he decides what gets investigated, whether criminal or certainly in the criminal law. And if someone dies unexpectedly or is found dead or there's any suspicion of foul play, then the police make a report to the Procurator Fiscal, who determines what further action needs to be taken, and he or she can order a post-mortem and further investigations to be made. And that's why we have such a high post-mortem rate. What else did we find? Well, 38% of all deaths under the age of 44 in Scotland in that 7-year period were due to SUDEP, so it's a not inconsiderable number. There were other causes of premature death which are worth considering: alcohol and drug addiction, drownings, and aspiration pneumonia. Drownings and accidents were a problem. So in conclusion, I'd like to thank Epilepsy Research, and I also have to, of course, to mention my collaborators, Gashirai and Bijou, guy on the left, who was our research fellow, who's done so much of the work. I get to come in and take the glory. In the middle in the pink shirt, Professor Richard Chin, who's been the epidemiologist and a great help and support. And on the right, Colin Simpson, who's now Professor of Health Economics at the University of Otago in New Zealand. So I think I'll stop now. Thank you very much.
Well, thank you for that, Dr. Duncan, Susan. Just a quick couple of questions there. On the slide where you detailed the deaths by age range, sorry if I missed it, but why are children not included, under 16s?
Well, the remit of the study was adults. So
right.
we started at age 16. There has been a paediatric study looking at death in young people under 16. In Scotland, you sort of leave the paediatric service at 16. So it was adults that we were looking at.
It's an extraordinary statistic that 38% of all deaths under the age of 44 are from SUDEP. That sounds remarkable statistic. I mean, did that strike you as particularly high?
No, I think it was what we had anticipated. We know that it's a big cause of premature death in people under about 45, and we don't entirely understand that. No, it didn't. I think what, if anything, surprised me was really the toll taken on people with epilepsy who have other problems such as alcohol addiction and drug addiction. That really is what surprised me. That these difficulties also foreshortened lives. But no, I had expected it would be a significant and major contributor of premature death.
And just one last question. Just one last question before I move on. Are there difficulties in definition here? You said, obviously, as you get older, people who die from SUDEP, is that difficult? Does that become more difficult to define? Because obviously, as you get older, there are probably more things that people can die of.
Well, I think in Scotland we can be fairly sure that this is robust because sudden deaths tend nearly always to be investigated. They either get a post-mortem, they usually get a post-mortem, or they get a very close look at. And of course, the pathologists can change death certificates as well. And they often do change death certificates to SUDEP if they are happy that they have just done a post-mortem on a SUDEP, although the original death certificate may say something else. So I think I'm fairly sure that this is robust. I am a little surprised that, you know, we had 1 or 2 people in their 70s who said to have SUDEP. But, you know, that's the reason we do research, just to discover new things, isn't it?
Yeah.
So I think we can be sure that it's robust, what we found, thanks to, in large measure, the way we do data collection in Scotland and investigate sudden and unexpected and unexplained deaths.
Well, thank you for now, Susan. We'll come back to you in a bit for a bit more of a discussion, but I want to hand over now to Dr. Amal Bandari, and Amal's going to be talking about his Epilepsy Research UK funded work in the lab on understanding the cellular mechanisms that cause SUDEP and their research towards a future biomarker test. So over to you, Amal.
Thank you, Andrew, and thank you, Epilepsy Research UK, for giving me an opportunity to speak on SUDEP Awareness Day about our project, where we try to understand the mechanisms of sudden unexpected death in epilepsy, and especially the role of cardiorespiratory neuronal control in its mechanism. So what we know about the sudden unexpected death in epilepsy and why it happens. So our past findings from labs and clinical trial, which is from hospital, tells us that the people who are living with epilepsy die from sudden unexpected death in epilepsy because their heart stop beating or lung stop breathing. And just to explain you how that happens or why it might happen. So here is the picture of brain, and here the lungs and the heart. And in the brainstem, there are these neurons that control our lungs and heart's activity. And that normally goes smoothly in the people who are living a healthy life. But in case of people who are living with epilepsy, seizure activity sort of spread on these cardiorespiratory nuclei and disturbs their function, which in unfortunate situation might stop the activity of these neurons and the neuronal function that could lead to sudden unexpected death in epilepsy because of the heart stop beating or lungs stop breathing. And the aims of our project were basically to record and monitor the activity of these cardiorespiratory neurons during and after seizure, and to understand what happens to these neurons when the seizure happens, and try to understand the mechanism, what are the neurotransmitters might be involved, or whether there are some ways that we can stop the spread of these seizure on these cardiorespiratory nuclei somehow. And one of the major goal that we wanted to achieve through this project is so far there has been a lot of research on the drug targets to cure the epilepsy, but still we have 1 in 3 people who live with epilepsy, and there are no drugs that can treat that epilepsy. And that's where our project comes in role, basically, where we are trying an unconventional way, or trying an unconventional approach, where we are trying to target these glia cells. These are the cells in the brain apart from the neurons, and they have a very significant function to play in our brain. And these glia have been proposed or shown that they play a very significant role in number of neurological disorders. And here we think that by modifying the function of these glia cells, we could probably prevent the spread of the seizure on these cardiorespiratory nuclei, and potentially could stop the sudden unexpected death from happening. And then moving on to our last aim, where we wanted to develop a biomarker test for people who are living with epilepsy, and potentially find who might be at significant, who might be significantly likely to have the sudden unexpected death in epilepsy. And this is hopefully, I mean, if this our aims and project goes well, we aim to design a simple breathing test to identify the subject that are potentially could have a SUDEP in future. And this test is basically where a person could breathe a specific mixture of gas, and these gases are the normal gases that we breathe every day, like oxygen, carbon dioxide, and nitrogen, but they will be in a specific proportion, and they will be taken through the mouth or lung, and then we will be measuring the responses or the changes in responses of the lung activity, and potentially that could tell us who are the people who are living with epilepsy are more at risk of developing the sudden unexpected death in epilepsy. And to moving on to the global research on epilepsy, and especially on the sudden unexpected death in epilepsy, one of that project was funded by Epilepsy Research UK at UCL, where they aim to analyze the brain scans of the people who have been passed away with SUDEP across the globe, and potentially find out what are the if there are any striking abnormalities in these brain scan, and could potentially lead to some great findings that will tell what might be wrong in these brain scan, and potentially we could develop some treatments to avoid those deaths. Then there are a lot of genetic factors play a very important role in SUDEP and seizure itself. So there have been a lot of research going across the globe to find out the genetic factor which might potentially put people into the risk of SUDEP. And then one more important aspect or the research is basically to monitor the people who are living with epilepsy, to monitor them in epilepsy monitoring unit by video and by their EEG, ECG activity, and potentially if they could pass, unfortunately, if they could pass with the SUDEP, then we could find the evidences like why that would have happened, and we could go into the mechanism. So that's the part of the clinical practice and clinical trial that are happening across the globe. And finally, there are a number of researchers who are working on the finding out what are the brain neurotransmitter that might make these brain changes to happen that might potentially lead to sudden unexpected death in epilepsy. And these are the major research projects that are going around the globe, but there are a lot of projects that are going and people are working on to find out the mechanism of sudden unexpected death in epilepsy and potentially cure epilepsy itself. So that's all from me. And finally, I would like to thank my supervisor, Professor Nicholas Dell. And this grant was basically given to me and Professor Dell. And thank you, Epilepsy Research UK, once again for providing us an opportunity to perform such a wonderful research for a better cause.
Well, thank you so much, Amal, and thank you for explaining what's obviously a pretty complex research that you're doing in such clear and accessible terms. Thank you so much for that. I just wanted to follow up quickly on the glia cells, and excuse my ignorance, but what else do we know about those cells? What sort of role do they play in our brains? What other functions do they have?
So the glia cell, they are as important as we know the role of the neurons. They are the supporting cells to these neurons. They can change the level of neurotransmitter in our brain, which is very, very important thing to keep the normal neuronal function. Otherwise, there will be too much concentration of neurotransmitter, and brain might just go out of control. So these glia cells all the time keep scanning our brain and keep the activity of these neurons under control. So they play a very significant role. And so far, our all research on epilepsy was mostly focused on neuron, because that's where obviously the neuronal function sort of gets out of control and a person have seizure. But the major factor that's controlling that from happening is again these glia cell, which sort of takes away those neurotransmitters that excite these neurons. And again, they keep scanning that brain all the time and these neurons and keep them under control and keep them calm. So they play a very significant role. And there have been a lot of findings where these glia cells are modifying their activity could lead to treatments for like symptoms like Down syndrome and Alzheimer's disease and Parkinson disease. And they are as important as in epilepsy as well.
Fascinating. Well, thank you so much again. I'd like to bring Susan back onto the screen as well, if we can, and so that we can hear from you again as well, because I wanted to launch into a question and answer session with you both, if that's okay, and talk a little bit more about you and your research. And so really, actually, the first question is, and maybe Susan, if you could answer this first, but what actually got you interested in this area of epilepsy research?
Well, I wasn't really until I was asked to speak, I think it was 2003, 2004, in a debate in Cardiff at the International League Against Epilepsy. And it was about whether you should tell patients when they were first diagnosed about SUDEP or not, or whether you should wait until people had got used to the idea of epilepsy and established on drugs. And it was an extremely acrimonious debate, I think it's fair to say, with some very strongly expressed views on each side. And at that time, I thought this is very interesting. A very firm agenda is being pushed that one should tell people about SUDEP immediately you make the diagnosis. And this is being pushed by a small group of people. And yet we have no evidence whether this is a good thing for the patient or a bad thing for the patient. What does the patient want to know? And so I wanted to set up a research project asking patients what they wanted to know about SUDEP. And finally, I achieved that a couple of years ago, thanks to the Scottish Government. And so that's how I got into this area. And then it seemed a logical thing to try and ascertain just how big the problem was in Scotland, how many people we were losing through SUDEP, with the broad aim of trying to prevent SUDEPs as much as possible. So that's how I got into it.
That's interesting, because actually one of the things I don't actually know about my sister Claire is whether she knew that SUDEP is something that could happen to her. I don't know if she actually knew that or not. Amol, how about you? How did you get into this area of epilepsy research?
Well, the journey has been quite interesting, and it goes back to when I finished my master's and I wanted to join for my PhD. And that was in 2012, where I got a research assistantship to the research assistantship in US at University of Virginia, where my the supervisor was working on epilepsy, not exactly on SUDEP, but generally on epilepsy. And I wasn't there for very long, but when I got admission for PhD in Australia, at that time where I was admitted, my supervisor over there, he was more into the cardiorespiratory neuroscience system. And my past experience from US on epilepsy, I thought, why not to maybe involve my epilepsy research experience with this cardiorespiratory mechanism. And that's where I found out about the sudden unexpected death in epilepsy, and how the cardiorespiratory dysfunction actually is responsible for these death in people with epilepsy. And I amalgamated these two areas of research, and where I actually got interested into SUDEP itself. And after my PhD, I moved at University of Warwick, and then that project was again the respiratory system, core respiratory system. And from there, I applied to the Epilepsy Research UK for funding, and we got this funding for finding out the reasons or the mechanisms for sudden unexpected death in epilepsy. So this has been a very nice journey, and what got me involved into this whole the sudden unexpected death in epilepsy research.
Thank you for sharing that story. Susan, the most recent statistics suggests that there are about an estimated 1,100 epilepsy-related deaths every year in the UK. So that's about 21 every week. With the research that's going on that both of you are involved with, do you think this number can and will change in the future?
Well, I very much hope so. One of the aspects of our research that we're not really allowed to publish, because the people that curate all of this data in Scotland are very hot on data protection, understandably, are individual case histories. But we have individual case histories which illustrate that changes in services could probably have saved lives. And I can think of 3 case histories we came on One, a man who'd had several seizures and even ended up in the acute medical assessment unit of the hospital in which he worked, and yet he was not once referred to a neurology service, which was mad. And then he had his drugs changed. He was on one brand of carbamazepine and he was changed to another, which we consider bad practice, and then he died. Another case, a terrible case of a young person who went into hospital for a very routine surgical procedure, and they were discharged on the wrong dose of anti-epileptics, too low a dose. The family queried it, the query was not dealt with, and a couple of days later the person was found dead in bed. And then there was another case of someone who had some mild cognitive impairment, who didn't have internet access, but they had been pointed towards information on the internet and they didn't get it and they drowned in the bath. And these are quite simple things that can be remedied, and there are 3 lives potentially saved. And also a lot of money saved, because one of those cases ended up in the Scottish courts. That's how I hope, on one level, the research we've done, it's not rocket science, it's not fancy genetics, it's just lining up your services and organising them. And it's a good way for trying to get more services, like more epilepsy nurses, who are a great support and often can deal very quickly with people phoning up and saying, oh, I'm having more seizures, and they can diffuse the situation by altering drugs or getting them in quickly to see the neurologist. So that's at the first level of what we can use our data for.
Thank you for that. I know you've had some interaction with politicians recently, and I want to come back to that and the public policy aspects of this. But turning back to Amol, you spoke about the biomarker test that you hope will be able to identify people more at risk of SUDEP in future as your research progresses. How long do you think it will take before this comes to clinical use? How long will that take if your research is successful?
Well, I mean, so basically this test is very simple. This is non-invasive, where we don't need to do any, the invasion. So this is very simple test, and if we get significant differences between the control and the, subjects with the epilepsy, then we can, ask for permission and proceed ahead with the clinical trials. And it could take somewhere between 2 to 5 years, because this is a very simple test. And if things go as per the plan, it could be, we could have results from clinical trial in 5 years' time. But that again depends on how things proceed.
And is it a test that you envisage people being able to take quite readily, or something they'd have to go to a hospital to do, or is it something even they could have in their own homes potentially? Well,
I mean, yeah, I think it needs a specific setup for you to have some specific gas mixture to breathe in. Obviously, you can have that at home, but again, to read out the changes in your breathing, we need a specific software to find out those changes and map that across the normal or healthy subject to see if there is actually difference, because you need some control line for that. So obviously for that you need some clinician who understand all that thing, and obviously specific setup where you can actually do that test. But yeah, as I said, it will be a very simple test, and we are very hopeful that we could get something out of it.
In the course of your research and the years that you've been studying this area, what sense have you got that there could be potential treatments that could prevent SUDEP?
Well, so the first thing is if you look at the motor, when motor runs fine, that means every part is synchronized properly and then they are running smoothly. But if something breaks down, there is some glitch in there, and that is repairable. So same thing goes with the most of the human health conditions. Some are just go out of hand, and that's where we can't cure the thing. So personally, I think with epilepsy, and especially where we know that 1 in 3 people live with seizure, and there is no drug treatment for that. So that's what got me more involved into this, the glial role into the mechanism of, the seizure and how they could control seizure. And I'm sure there hasn't been much focus on these glial cells. And I'm confident that, that was the lack of knowledge, our lack of knowledge. And I think having more focus and more research done on the part of the glia and their involvement into the seizure and SUDEP would tell us where the things are going wrong, and just not the neuronal control, but the supportive cell. They are itself not performing properly or not doing their function properly, and that's why the neurons are not able to perform to their the healthiest capacity. So I think there is a huge hope, and obviously the genetic mutation and genetic abnormalities, that is something is always changing and happening. So we will be able to cure seizure and epilepsy to a lot better extent, but again, there will be some condition or genetic mutation which needs specific attention, and that's not maybe the part of glia, but that's something with the genetic makeup itself. So, but yeah, we can definitely have a better treatment, and a lot of people, more people could live a seizure-free life in future.
Fantastic. Susan, similar question to you in a way. I mean, how do you see the results of your research being used? I know you recently went to the Scottish Parliament to talk about your research, and maybe if you could talk to us a little bit about how that experience was and how that went, and how talking to politicians potentially can change things.
Well, yes, we had. There's the Scottish Parliament Cross-Party Epilepsy group, which meets every so often, and is organised actually through Epilepsy Scotland, which is a charity in Scotland. It's a variable thing, because sometimes lots of politicians come, others don't, depending on what happened in the chamber. I think the advantage of Scotland is it's a small country. 70% of us live in the Edinburgh-Glasgow corridor, so you can get to Holyrood and to politicians easily. On the other hand, because it's a small country, it is at risk potentially always of one group getting a grip on things and influencing. So, and the other fear that politicians all have is that you go along and you want money. I think our talk went down well because we were able to illustrate that we could make a significant change really just by rejigging the services we have and by raising awareness and saying that, really it's not good enough to have a system whereby if you have a seizure on the street, you get taken to accident emergency, you're seen briefly and you're allowed to go home. We really have to have a mechanism, and possibly more nurses, so that there's a nurse in accident emergency who'll get called, who'll say, right, and other ways that we can, and talking to politicians about waiting lists. There is this huge fixation on waiting lists and a fear that waiting lists will grow. And this means that they're rigid about changing the way services are delivered. And yet one very easy service delivery change we could make is, instead of having this rigid idea that you come and see me every 3 months or 6 months, is to say, right, 3 afternoons a week, someone's going to be in the outpatient clinic, either phone us or come and see us if you're having more seizures, or if you're getting side effects, or if you're not happy with something. And that it would probably deliver a much better service than we have been doing. So small things like that, I think they were receptive, and I think it has boosted the profile of epilepsy. But it's like all things, epilepsy is a minnow compared with cancer and heart disease, which are the diseases that dominate the medical agenda, and of course are what people get worked up about and want good services for, and the politicians respond to that in kind.
Yeah, that's absolutely fascinating. So just simple changes in the way we do things could do so much here without having, as you say, without the need to spend millions and billions of pounds. Do you think what you've been talking about the Scottish Parliament, can this be sort of spread around the UK as well, more generally?
Well, I hope so. I mean, we published some of our data, and we're in the process of publishing others, and we've presented the data. Gasher, our research fellow, has presented with great success and won prizes. I do know that there was a project in Wales where they did this sort of open access system. And that has worked quite well. I think we're increasingly probably just moving towards that because of the way our epilepsy nurses work, in that thanks to COVID, but even before COVID, they were increasingly doing telephone clinics and putting out their email address and their telephone number, and people just phoning directly and saying, I'm in trouble. So I think that change was creeping in already. I think the medical staff, the medical profession, particularly those of us who do epilepsy clinics, have to sort of catch up a bit, and that's what I'm hoping will happen. So yes, I think in the next couple of years, I hope we'll see changes in the way this sort of service, this level of service to people with epilepsy is provided. And also that we will quickly identify those people whose seizures we are not controlling, even with the best of drugs, to see which of them might be suitable for surgery. We know that generalized tonic-clonic seizures are a big risk factor for SUDEP. So if you can't control them with drugs, to try and look at other ways of controlling them, and surgery can be an option in some people. So you need to identify these people, and they need to be seen, you know, in a centre that has an epilepsy surgical service, because it's a very specialised area.
Amal, coming back to you, we're obviously focused on SUDEP today, but do you think your research will help us understand about other aspects of epilepsy? I mean, in many ways, there's so much that's still unknown about epilepsy itself.
Yeah, I mean, so although the project is mainly focused on how these seizures spread onto these cardiorespiratory nuclei and recording the activity and finding out what might be going wrong there, obviously knowing more about the glia cell in the cardiorespiratory neuronal region, we would know more about their function. And on the same side, as when we will be correcting the function of these glial cell to cure the SUDEP or to prevent SUDEP, we will know whether these subjects have more of the seizure or whether their frequency decreases. So obviously, when we are trying to tackle the sudden death, we will know whether these subjects get less number of seizure. And we are hopeful that, and that's where I mentioned 1 in 3 people who live with the seizure, those seizures could be cured by targeting these glial cell. And that's where the future of this project is basically to looking into the findings of our project, taking them on to the next step, and trying to deal with the pathophysiology of seizure itself, where we could prevent those seizure or maybe increase the threshold in people so that they would have less seizure, and we potentially could cure these untreatable seizures then.
Fantastic. Susan, just one other question for you. You were on Women's Hour on Radio 4 recently, talking about how women with epilepsy are disproportionately affected. Could you just quickly tell us about that and what you were talking about on that program?
Well, the Women's Hour experience was very interesting. I think audio broadcasting, radio, is an excellent way of exploring topics like epilepsy and discussion, much better than I think TV. I think the BBC suffers from giving interesting topics too short time. They gave us 13 minutes, which they thought was very generous, but I'm not sure it was. And I think other radio stations are exploiting that. I was looking at Times Radio. They have Mariella Frostrup holding forth for an hour on one topic the other day. So I think, as a general comment, what I was talking about was does epilepsy have a greater impact on women than men? And I suppose it does, because of our hormonal makeup. And talking about catamenial epilepsy, this is a phenomenon of seizures becoming more frequent or severe at certain points in the menstrual cycle. And really, despite it being discussed and looked at for years, we've only got one decent study of treatment of catamenial epilepsy, which actually turned out to be negative, which is a shame, because we know that in our brain we have steroid receptors which will alter seizure thresholds. So if you could get a good treatment, a steroid treatment, it might benefit the whole of mankind, not just women. Then, of course, there's a whole panoply of pregnancy and epilepsy. men don't have to contemplate 9 months of pregnancy, but this is very important. Women can have find an increase in seizures during pregnancy. They have to think about the effects certain drugs might have on the unborn child. So ideally, women have to plan ahead before they get pregnant, see an epilepsy nurse, perhaps be changed onto a better drug for them, take folic acid. And then there has to be a plan for them for their delivery and postpartum period. And talking about death, as we have been, we know that women with epilepsy are at greater risk than their non-epileptic sisters in the first year after birth and the postnatal period of death from epilepsy. That has been shown, and it's SUDEP. Often it's women, they get very tired, they may forget the drugs, or it's accidents. I've been cases of women drowning, falling asleep in the bath, or having a seizure in the bath because they've been bathing unsupervised. So that's an important period as well, where women can be adversely impacted. Then, of course, there's the whole question of the menopause. I have patients always ask me about the menopause, but we do very little research into that. And finally, coming through the data is a suggestion that women with epilepsy may be more at risk of domestic abuse than women who don't have epilepsy. There was a study recently from Norway looking at women and children, or women and babies, women in baby cohort. And there's no doubt that the women with epilepsy reported higher levels of domestic abuse than the women who did not. And there's another study done from Bristol University, again suggesting that people with epilepsy in general may be more at risk of domestic abuse. Now, they looked at both men and women, but women are, as we know, more likely to be abused than men. So there is that coming forward. Are women with epilepsy also more at risk of this than their male counterparts? So it's not an area we've investigated. So there's lots of reasons why I think the burden of epilepsy may fall more severely on women than men in certain areas of life. Anyway.
Well, we've had a little longer than 13 minutes today to speak, but it's never enough time. The research that both of you are doing is so fascinating, so valuable. I just wanted to close by asking both of you then, looking into the future, what your hopes are for future research into epilepsy and for people who are living with epilepsy. Maybe Amol, you go first, but Susan, feel free to join in.
Yeah, I think as I said in past as well, we have a great hope that we could make people who are living with epilepsy, we could make their life a lot better and definitely prevent a lot of sudden unexpected death in epilepsy. And I mean, just an example, this biomarker test that we are hopeful to develop, that will definitely play a huge role. Because we know about the SUDEP from decades, but why we are not able to treat them or prevent them? It's just because it's hard to look at each and every person who is having epilepsy. But if we get this test and narrow down the number of people who might be at higher risk, then we could spatially give them a spatial care and treatment, as Susan mentioned, that just by making these frequent visit to the hospital could make could save a lot of lives, because people don't visit quite often because of a lot of reason. But narrowing down that number who might need special care and making them to visit the hospital frequently could prevent a lot of sudden and unexpected death in epilepsy. And again, the role of these glial cell, they have been proved to be very significant in a lot of neurological disorder, and we are hopeful that we could again have some good discoveries in epilepsy research, and by playing with the cell roles of these cells, we could cure unprevented seizure, or the seizure that can't be cured with the current drug treatments. And I mean, that's where the charities like Epilepsy Research UK do come in, role, and they play a very significant role, because researchers like me can't be funded maybe through a big organization, but charities who are dedicated to, to cure the epilepsy and, the death from epilepsy, they do fund these fantastic research where we have a huge and, the future hope to cure epilepsy and stop the sudden unexpected death in epilepsy. And again, we need to work hand in hand, like clinicians like Susan, and lab-based researcher like me, and the general public who have an actual experience from their the close relatives or their friends and family. And then, yeah, we just need to work hand in hand with the charities and the funding agencies to deliver, future hope for all of the society and people who are living with epilepsy. And we are very hopeful for that.
Susan?
Well, yes. I mean, I think the immediate offshoot, I hope, of the work we've been doing is that we're going to use the data for case-controlled studies. So that will give us an idea of the differences between those people who die of SUDEP, young people who die of SUDEP, compared with other young people with epilepsy who don't die of SUDEP. So that's going to be the next thing we're doing. And then we hope in Scotland, because we're small and compact, to be able to set up a prospective death registration system so that we can explore in greater detail the clinical and biological causes behind death. So to try and get biological specimens from people who've died before their time, particularly those from SUDEP. So I think that's going to be a thing. In the future, I mean, I think it's very exciting. Amal talked about the control of the respiratory chain and so on. We discovered anti-epileptic drugs. Some of the commonest used anti-epileptic drugs, old ones like phenytoin, phenobarbital, carbamazepine, were discovered serendipitously, really, and now we know why they work. They work on sodium channels in our head, and we know that some other drugs work on calcium channels and potassium channels. So finally, we know why some of these drugs work. And we also know that subtle genetic alterations in these channels can determine whether you respond to drugs or not. And the pediatricians now know that certain sodium channel blockers will make some sorts of epilepsy in their children worse, but will greatly improve once they've done the genetic tests. So I think in the future, we're going to learn more about these channels and test for them genetically and tailor drugs better. I think that's the first thing. I think secondly, we are possibly going to look more about the role perhaps of inflammation in the genesis of epilepsy, and try and come up with other ways of discovering anti-epileptic drugs. Amal has quite rightly said that since the 1950s, the prognosis for seizure freedom has not improved despite all the drugs that we have now. And that's because we keep using the same animal models and the same laboratory models. We're now coming up with different laboratory models. And I think that will bring out a new generation of drugs that work perhaps differently in the brain, which will have great advantages. One of the most commonly used drugs now, most successful drug, is levetiracetam. Levetiracetam does not work in the majority of epilepsy models in the lab. I think it only worked in one, and it nearly didn't get developed, and yet it's been one of our most successful drugs. So I think we need different models for drug discovery, and we just have to reorganize ourselves so that our services are more streamlined and more immediately accessible to our patients.
Well, thank you in particular to both of you for giving up your time and to talk to us all today. And I certainly learnt a huge amount. Thank you more generally for your expertise, for the dedication that you've shown to your research, such valuable work that you're doing, and for people who have been affected by epilepsy. It's so important to know that such wonderful research is going on. So thank you, both of you, for taking part today. And with that, I'll hand back to Caoimhe.
Hi, everyone. So thank you so much to all of our speakers for taking part in this discussion today. I've just got some summarizing comments that stuck with me from the discussion. And I think it's just been so insightful to hear of this research that's happening across the UK and internationally, actually. And from Susan's talk, we were able to hear about the research that's been done in Scotland to identify ways that we can prevent epilepsy-related deaths in the near future. And as you said yourself, Susan, it's not rocket science. It's this streamlining of services, which of course, as we know, are currently under huge pressure due to the ongoing pandemic. And similarly, from Amal's talk, we saw what is happening to understand more about why SUDEP happens and what are these underlying mechanisms, but also the hope that in the future, research may lead to what seems like a simple breath test that could identify people who are at an increased risk so that they could have these these enhanced care provisions in place. And as you said, Amal, working hand in hand with researchers, clinicians, and of course people affected by epilepsy to achieve this. And we will have some information below on how if you've been affected by epilepsy or an epilepsy-related death, how you can get involved in epilepsy research and shape future research into epilepsy. We'll have that information just down below. But of course, a huge thank you to Andrew for not only hosting this session, but for sharing the extremely moving story of your sister Claire and her life and what your family has gone through in that devastating loss. And of course, sadly, we know that your family isn't alone in this loss. Every week in the UK, around 21 families go through losing a loved one to epilepsy. And so we do understand that for some of you watching this webinar, the topics covered may have been upsetting, and we will be sharing the phone number for the SUDEP Action Helpline on screen shortly, and they offer specialised bereavement support. And I hope that the panel will agree that there's a real feeling of hope for the future, that through the research we are working towards preventing a number of epilepsy-related deaths. So again, a huge thank you to Susan, to Amal, and especially Andrew for taking part in today's discussion to mark SUDEP Awareness Day. So thank you.